Dear audience, ladies and gentlemen, I'm delighted to present you my Ph.D. topic entitled The Progression of Acute Pancreatitis. My name is Endre-Botond Gagyi. I am a second-year Ph.D. student at the Center for Translational Medicine at Semmelweis University, Budapest, Hungary. My supervisor is Bálint Erős, my SMS is Mahmoud Obaidad, and my statisticians are Daniel Sándor-Veres and Adam Zolczak. My vision regarding to this topic is that we can reach a state where we can prevent most of the patients from the recurrence and the progression of acute pancreatitis, and my mission is to reduce these recurrence and progression rates. Here you can see a brief overview of my research projects, each focusing on the progression of acute pancreatitis. In the first one, we investigated the incidence of recurrent and chronic pancreatitis after an acute episode. In the second one, we investigated the risk factors associated with this progression. And in the third one, we investigated the proportion and characteristics of CP patients without any prior acute pancreatitis episodes. So the first one entitled The Incidence of Recurrent and Chronic Pancreatitis after Acute Pancreatitis, which is a systematic review and meta-analysis. In this project, we investigated the recurrence and progression of acute pancreatitis according to the different etiologies and the severities of the first acute pancreatitis episode. This project was published in the Therapeutic Advances in the Gastroenterology journal. Our second project, entitled The Risk Factors of Acute Pancreatitis Progression into Recurrent Acute Pancreatitis and Chronic Pancreatitis, which will be also a systematic review and meta-analysis. Let me briefly introduce its background. The incidence of acute pancreatitis varies globally, affecting from 5 to 80 people per 100,000 and appears to be increasing around the world. Most acute pancreatitis can be completely recovered after standard treatment, but the proportion of patients eventually develop recurrent acute pancreatitis up to 35% or chronic pancreatitis up to 24%. On the right figure, you can see the sentinel acute pancreatitis event model by Whitcomb et al., which states that acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis can represent the disease continuum. Data on the risk of developing REP and CP and the factors affecting disease progression have been heterogeneous. However, in order to reduce these recurrence and progression rates, it is essential to know all the contributing factors of progression. Therefore, our aim is to comprehensively assess and objectify all the factors that can contribute in the progression of acute pancreatitis. We would like to identify risk factors at this second stage, specifically focusing on factors that contribute to acute pancreatitis progression rather than the risk factors for AP itself. As our study investigates the risk factors of AP progression, we use the PO framework for posing the question. Our clinical question is, what are the risk factors of AP progression into REP and CP? And the population includes patients with the first episode of acute pancreatitis or patients with recurrent acute pancreatitis. The exposure involves the presence of risk factor, and the outcomes are either recurrent acute pancreatitis or chronic pancreatitis. We hypothesize that the presence of a risk factor increases the risk or odds of developing recurrent acute pancreatitis or chronic pancreatitis in these patients. To achieve our goal, we have done a systematic search in 3 major databases in PubMed, Embase, and Cochrane Library on the 19th of December 2023 using this search key. Here you can see the flowchart for selection. Out of 25,000 articles, we included 124 in the quantitative synthesis after the title and full text selection. Before I present the results of our meta-analysis, I would like to emphasize a crucial aspect of our findings. What we identified here are significant associations, not definitive proof of causation. On this forest plot, we investigated the association between diabetes mellitus and the odds of recurrent acute pancreatitis. 9 retrospective and prospective core studies were included in the analysis. The exposure group included patients with acute pancreatitis and diabetes mellitus, while the comparison group included patients with acute pancreatitis without diabetes mellitus. The event of interest was the development of recurrent acute pancreatitis. As we anticipated considerable between study heterogeneity, a random effect model was used to pool effect sizes, and for the effect size measure, we used odds ratio with 95% confidence intervals. The odds ratio here is 1.5, and this means that among patients with acute pancreatitis, the presence of diabetes mellitus was associated with an increased odds of recurrent acute pancreatitis. And since the confidence interval does not include 1, this result is statistically significant. Here we investigated the association between hypertriglyceridemia and the odds of recurrent acute pancreatitis. And in this case, we found that patients with acute pancreatitis and hypertriglyceridemia had a more than 2 times higher odds of developing recurrent acute pancreatitis compared to patients with acute pancreatitis without hypertriglyceridemia. After looking at the association between local complications and the odds of recurrent acute pancreatitis, we found that among patients with acute pancreatitis, the presence of local complications such as pseudocysts or acute peripancreatic fluid collections were also associated with an increased odds of recurrent acute pancreatitis. On the first figure, we investigated the association between anatomic abnormality and the odds of recurrent acute pancreatitis in the pediatric population. In this case, we found that among patients with acute pancreatitis, the presence of anatomic abnormality was also associated with an increased odds of recurrent acute pancreatitis. On the second figure, we investigated the association between genetic mutations and the odds of chronic pancreatitis. In this case, we found that among patients with recurrent acute pancreatitis, the presence of genetic mutations was associated with an increased odds of chronic pancreatitis. Additionally, our study identified alcohol consumption and smoking as sequential risk factors. They not only significantly increased the odds of recurrent acute pancreatitis, but also the transition from recurrent acute pancreatitis to chronic pancreatitis. Considering the strength of our study, this will be the first meta-analysis investigating the risk factors of acute pancreatitis progression into chronic pancreatitis. Its comprehensiveness, it covers a wide range of factors, investigating 62 different parameters effect on the progression of acute pancreatitis. Also, our study identified alcohol consumption and smoking as risk factors in all acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis axis. Considering the limitations, the majority of the included studies were retrospective and obviously the presence of the confounding factors. Considering the clinical implications, we have so far identified several modifiable risk factors, which is clinically important because by eliminating these risk factors, we may be able to reduce the recurrence and progression rates in these patients. Also, the identified risk factors can help the clinicians in the risk stratification of these patients. Our study also draws attention to the needs of patients' awareness and highlights the importance of secondary prevention, such as cholecystectomy, hypertriglyceridemia treatment, alcohol smoking cessation, diet, lifestyle changes, etc. And our study also highlights the needs for prospective multicenter studies assessing acute pancreatitis progression with longer follow-up times. This is the current status of our second project. We would like to submit it to the American Journal of Gastroenterology. Our sub-project will be also a systematic review and meta-analysis, and it also focuses on the progression of acute pancreatitis. A few words about its background. The annual incidence rate of chronic pancreatitis varies between 5 and 12 cases per 100,000 person years. Chronic pancreatitis is a severe condition that greatly deteriorates quality of life and reduces life expectancy, and currently there is no specific curative treatment available. A common belief is that acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis represents a disease continuum as previously illustrated by the sentinel acute pancreatitis event model. This model posits that a sentinel acute pancreatitis event sensitizes the pancreas to recurrent acute pancreatitis, which subsequently leads to chronic pancreatitis as a result of ongoing stressors and inflammatory responses. While the sentinel acute pancreatitis event model is an interesting hypothesis, it implies that all chronic pancreatitis originates from acute pancreatitis. However, a considerable number of chronic pancreatitis patients have no history of prior acute pancreatitis episodes. In light of this discrepancy, our aim is to comprehensively assess the proportion and the characteristics of chronic pancreatitis patients with no history of prior acute pancreatitis episodes. This will provide a more comprehensive understanding of the relationship between acute pancreatitis and chronic pancreatitis, and will help refine the existing models of disease progression. So for this study, we have two clinical questions. We would like to know the proportion of chronic CP patients with no history of AP, but at the same time, we would like to know the specific characteristics of this patient population. How do they differ from other chronic pancreatitis patients? So we have done already preliminary research. We found the key articles, the topic is feasible. So a brief summary. I would like to finish the second project by the end of July and the second one by the end of this year. So here you can see my additional activities. I have presented my work in lots of conferences and where I was a co-author. And thank you for your attention.
very elegantly left out the first study because that is history anyway. So we cannot ask anything about that. But if you want to be very picky, I mean, in your first study, the first forest plot, not picky, I mean, that's just interesting. To say that I always look for same authors if there are multiple papers and so on. There is something very interesting here, that you et al. In 2020, with no diabetes, they have 51 cases out of 466. In 2022, only 1/3 of the patients, they achieved actually the same number. So I mean, so the incidence of the event is actually 3 times higher. So is there any clue on this?
There is no relation between the two studies. So
Still, I mean that this is just no diabetes, and okay, the number of events are 3. So there must be something either different from the two studies, different ways of selections.
The proportion of hypertriglyceridemia etiology, hypertriglyceridemia-induced acute pancreatitis is much higher in the U et al. 2021.
Yeah, that's the point.
There's a significant difference between the two studies.
To me, that is strange anyway. I mean, that if they do that in a different way. You had only one slide, and then there's so many data. I mean, on mutations, there was one, I think, coming after. So, are all mutations born equal? Okay, in the lower part.
All the 3 studies there reported 4 types of mutations: the PRSS1, SPINK1, CFTR, and CTRC.
So they just put them together?
Yes.
Because that would be interesting to see if there is any difference. I mean,
yes.
That you always have questions which, I mean, you cannot answer, of course. But for understanding the whole pancreas kind of pancreatitis development issue, that will be very good at one day, that if you understand this actually. I mean, the differences between different, this kind of details, not only that they actually increase the onset of a certain type, but also that what is happening actually afterwards.
Thank you, congratulations. So in your second project, you investigated multiple risk factors, am I right? So how many?
62
parameters. So my question is this design suitable also for network meta-analysis, or is this not suitable for network meta-analysis? And if it's not, why not?
It is not suitable because there is not enough RCT for that. So we can only do a network meta-analysis with RCTs. So one of the reasons.
I just also wanted to ask, so if I understood why you checked these 62 parameters, does it mean that they were 62 different conditions, chronic diseases, whatever, that could potentially, or what kind of parameters were these?
Every kind of lab parameters, comorbidities.
Because actually my question was, I wanted to ask whether, have you found any chronic disorders or diseases which did not increase the risk for this progression from acute pancreatitis to chronic pancreatitis? So, because for me it's logical that if there is a chronic disorder like diabetes or hypertriglyceridemia or alcohol consumption, whatever, then the risk should be, if we analyze enough patients, probably higher than if they are absent. So that's why I ask whether have you found such concomitant diseases which do not increase the risk for this progression?
For instance, hypertension not really increased. So, almost was a protective factor, hypertension.
Okay. It's good to know. I have hypertension, so it's good to know. Thanks.
Congratulations to your presentation. Actually, I would like to ask about the plot with diabetes, and I would like to ask what type of diabetes we are speaking, what type of population is here, and if there are multiple diabetes, did you consider the subgrouping by the type of the diabetes, etc.?
Yeah, it would be really nice to have data about that, but so there is no data about the type of the diabetes. So I would assume it's like 90% would be type 2, but there is no data specifically.
A very good presentation and progress. So I had a question about the anatomical abnormality, if I'm not mistaken. One of the articles was, the odds is like 45, which is clearly an outlier and very far from the other articles. Is there any explanation in the article why did this happen?
One potential explanation could be that, as far as I remember, this article includes maybe all of the patients were idiopathic etiology of pancreatitis. So that could work.
Thank you.
So congratulations. As you have showed us the forest plots, I could notice that almost all of the studies are from Asia. Why do you think that that is the case? So you found these dominance in Asian studies. Do you think there is something underlying this?
So which outcome do you refer?
So
because altogether there is not Asian dominance. So
for example, in
124 there is pretty much half and half. So there is a Europe and Asian dominance and much less article from America.
Okay, thank you.
If I may have one question. Also, it came to my mind, like when we go to the diabetes mellitus slide, basically I assume, if you are speaking mostly about diabetes 2, that patients in the group with no diabetes would be younger, probably. So was there any information in the literature where they adjusted for confounders, for example, like for age, etc.?
So basically, there is absolutely, so if you can imagine, so there is one group with AP, one column with AP, one column with REP, and they just in the row mention the diabetes myth, so it is a limitation of the study, so there is absolutely no explanation for this parameter.
I have also one additional question. So, related to this result. So it's known that different anti-diabetic drugs can increase the risk of pancreatitis. Do you think that these drugs have any influence on this result?
Yes, it's a very good question. Yes, so there is.
Did you check, for example, with which drugs so these patients were treated? Because some drugs are more dangerous and others not really for the pancreas. So or could you do such subgroup analysis related to the anti-diabetic drugs that are used here?
There is no data about this, unfortunately.
So you are a resident too, aren't you?
Not yet.
Or not yet? Okay, but you want to be a resident? Okay.
Yes.
Okay, so how will it go to your clinical practice, what you actually learn from these studies? Just very general question, don't worry, very general.
Sorry, I didn't
Sorry. You got, everything and everything. I mean, you have a study, based on acute pancreatitis going to kind of different directions, consequences. So how does it go to your clinical practice or the group where you work at?
This result?
Yes, the results, yes.
So
just explore a little bit.
I expect from this study to provide a list with the significant associations, which, when I met a patient with acute pancreatitis and I recognize this kind of risk factors, that will influence my treatment or how I will treat this patient.